Hello everyone, welcome to Dental Shots. Today we are going to see about facial palsy. If you have not subscribed to our channel, kindly subscribe to it and let's move on to the video. The facial palsy can be a upper motor neuron or a low motor neuron. We have to find the etiology of facial palsy and we have to do an effective treatment because the facial palsy has a significant deterioration in the quality of life. What is the cause of facial palsy? First cause would be an unknown cause which occurs mostly, that is 70%. The cause is unknown. We call it as Bell's palsy. It is a lower motor neuron lesion with a total unilateral palsy. Recurrence rate is about 10%. The facial palsy can also occur after the trauma, which contributes about 10 to 23% of all facial palsies. So mostly the fracture of the petrous part of temporal bone, when it is occurring, then the Bell's palsy can occur. Even the facial wound which transect the branch of facial nerve, and if the clinical history is very much important to identify the cause of etiological origin of facial palsy. The next cause of facial palsy is the viral infection, which contributes about 4.5 to 7%, and the herpes zoster infection, which involves the geniculate ganglion, causing the inflammation of the ganglion, which we commonly call it as Ramsay-Hunt syndrome, involving the glossopharyngeal nerve. Additionally, up to 40% of the patients involve the 8th cranial nerve too. Certain bacterial infections are also responsible for the Bell's facial palsy, like acute otitis media can cause a dehiscence in the facial canal, resulting in the nerve paralysis. Sometimes cholestoma and also necrotizing otitis externa. In a rare case, even the Lyme's disease can cause a facial palsy. The neoplasia, the malignancy, can cause a slowly progressing facial palsy. If you see a case which has a slow progression rate of facial palsy, then you have to suspect a case of malignancy, so that you have to do a thorough head and neck examination. Most of the malignancy involving this facial palsy are parotid malignancy, facial and acoustic neuromas, and meningiomas. Arachnoid cyst can also cause facial palsy. So based on the location of the tumor, there will be a varying degree of manifestation of facial palsy. We have to see a facial nerve palsy, especially in children. As we already saw the etiology, that may be the cause of facial palsy in children, but the other causative factor is the congenital cause, that is high birth weight, forceps delivery, prematurity, or birth by cesarean section can also cause a facial nerve palsy in children. Okay, and then the genetic cause would be attributed to the chromosome loci 3q21 and 22 and 10q21.3 and 22.1. Some syndromic cases can contribute to the facial nerve palsy in children, and surgical decompression of the facial nerve within the labyrinthine segment is not indicated in pediatric patients. Most of the facial nerve palsy will be unilateral, but if you see a bilateral facial nerve palsy, you have to suspect Lyme's disease, because 35% of the cases of Lyme's disease has a bilateral facial nerve palsy, or it may be a case of Parkinson's disease, multiple sclerosis, and pseudobulbar palsy also. So this bilateral cases are totally about 0.3 to 2% of all facial palsy and 20% of the idiopathic origin. Now we are going to see the epidemiology of facial palsy. Most of the cases are idiopathic, and we have to rule out a cerebrovascular event or underlying pathology. There is no much difference between the gender and the race, and mostly it would be 15 to 45 years group of age are mostly affected, and Bell's palsy contributes to 70%, trauma contributes to 10 to 23%, viral infection of 4.5 to 7%, and malignancy of 2.2 to 5% contribute to the facial palsy. The pathophysiology of facial palsy is dependent on the etiology, depend on the cause of facial palsy. Due to the facial nerve ischemic changes through compression, or there may be a skeletal abnormality, or it may be a trauma which results in a disruption of relationship between the facial nerve and its bony canal, causing the paralysis. Some iatrogenic causes of facial nerve palsy has also resulted because of surgery. Let's now see how to differentiate between the upper motor neuron lesion and lower motor neuron lesion. In upper motor neuron lesion, the forehead will be spared, okay? But in the lower motor neuron lesion, the entire facial movements are compromised. So apart from the presence or absence of facial nerve paralysis, you can also assess the degree of facial nerve paralysis by a system called House-Brackman grading system. I don't want to go into a detailed version of it. If you want to see it, you can pause the video and have a look at it. To assess the facial nerve paralysis, there are additional tests like corneal reflex, Schimmer's test, tapedial test, salivary test, and taste test. What are the use of blood tests in the evaluation of facial nerve paralysis? So full blood, urea, electrolyte and C-reactive protein are assessed to find out the infectious cause of facial palsy. In case of Ramsay-Hunt syndrome, we have to find out the antibody titer of varicella zoster virus, and if it is a Lyme's disease, we have to check the immunoglobulin G and M. Apart from the blood test, there are special tests for evaluation, that is the audiogram, electrophysiological test, minimal to maximal stimulation test, electroneurography and electromyography, magnetic stimulation. Imaging such as computer tomography and magnetic resonance imaging are useful in the evaluation of facial palsy. And coming to the treatment and management, first, we will see about the conservative management, especially the eye care. We can use an artificial tear, adequate lubricant, and tapping the eye closed at the night ensures the prevention of corneal ulceration. And you have to do a facial massage with the facial exercise also as a conservative management. The medical treatment are the use of steroids and analgesia within 72 hours of symptom onset. And also the prednisolone would be 50 milligram. Once a day should be commenced for 10 days. So if you want to reduce the steroid level, the reducing regimen should be preferably reduced 10 milligram for a total treatment duration of 10 days. So if you see a bacterial infection case which require intravenous antibiotic therapy may be needed. In case of Lyme's disease, if the patient is over 8 years, then you have to give 200 milligram once daily doxycycline for totally 10 days is recommended. And if they are under the age of 8, there would be a 14-day course of amoxicillin or cefuroxime to avoid the potential tooth staining with tetracycline use. Surgical decompression would be a treatment option, but it should be weighed with the benefit and versus risk. If the benefit is more, then you can go ahead with the surgical decompression. So in case of a iatrogenic cause, you have to do a surgical decompression, but you have to watch by waiting. Sometimes you are sure that your iatrogenic cause is absolutely responsible for the facial nerve palsy, then you have to do an urgent re-exploration. And in case of over tight packing in the open mastoid surgery also, you may require a removal of packing which you done it very tightly. And in temporal bone fracture, we have to do a nerve decompression as required immediately. The emerging treatment option is the transcutaneous nerve stimulation, which is mostly used in the unilateral facial nerve palsy. It cannot be used in the bilateral facial nerve palsy because the EMG signals from the muscles on the intact side of the face will simultaneously stimulate the corresponding muscle on the side of paralysis. So the ultimate aim of this treatment is to achieve the facial symmetry. So the Bell's palsy, Ramsay-Hunt syndrome comes under lower motor neuron lesion, and stroke, multiple sclerosis, subdural hemorrhage, intracranial neoplasia causing facial paralysis comes in under upper motor neuron lesion. On seeing certain criteria, you can definitely say that the prognosis is poor. The factors are complete palsy, loss of stapedial reflex, no signs of recovery within 3 weeks, and the age is over 50 years, Ramsay-Hunt syndrome, and poor response to the electrophysiological testing. If 6 criteria is any one of them, if you see, then the patient will have a poor prognosis. The complications of facial nerve palsy, the first one is exposure keratitis. Due to the drying of cornea leads to ulceration of the cornea. The second complication is the hemifacial spasm, that is the one half of the face undergoes an involuntary muscle contraction. This can be treated with the muscle therapy and also botulinum toxin therapy. The third complication is the synkinesis, which is the voluntary facial movements that is accompanied by the involuntary movements. In this case also we can use a facial muscle therapy. Hope this video would have been a knowledgeable one for you. If you like it, comment below regarding this video, share it with your colleagues, and subscribe to Dental Shots for further notification of new videos, and don't forget to hit the bell button. Have a great day. God bless you all. Thank you.